All right, guys, welcome back to the Dr. Doug Show. Today, we're going to talk about labs. We get a lot of questions around labs. What labs should I run? What do the labs show? My doctors won't do labs. They won't tell me what it shows. There's a lot of confusion around labs. So what I want to do in today's video is I actually want to show you the lab results from one of our patients. And of course, we're taking all the names out, so you won't know who this is. But I just want to go down what each of the labs shows. And then I want to talk a little bit about reference ranges, because the reference ranges we get from LabCorp or Quest or whatever lab company you're using, in general, those are statistical averages of the population. So especially for postmenopausal women, some of these reference ranges are absolutely pointless. For example, total testosterone, actually even better, free testosterone for women, the reference range goes to 0. Clearly 0 is not something we're shooting for, right? So when we look at labs, we have to understand what is the reference range and then also what is the optimal range. And there's lots of different ways that you can calculate that. We have our own set up, and I'll walk you through those on this lab panel. But I want to go through each of these labs. So if you're on a bone health journey, if you are trying to prevent chronic disease, you are trying to improve your lifespan and health span, this might be a valuable video for you to watch so that you can understand how we as a health span company, essentially health optimization, bone health through the lens of health span company, are looking at these serum biomarkers and what we're doing with them and how we're adjusting them for an optimal range and how we look at these biomarkers. Okay, so I have in this list of labs, you'll have some screenshots of this as we go. But basically, this is a patient of ours who had an initial visit back in November, and now she's had a follow-up visit in June. Our program, our clinical program and our community are run in 12-month segments, and we do 12 months because it takes time for these things to change. In the 6-month follow-up, what you'll see in here is that, if, for example, something isn't looking right or if it's looking worse, it's really important to retest so that you know that what you're doing is working or not working. So again, we're going to go through all these labs. So we have these divided up, and as they come out, let's say from LabCorp, for example, you get this printout. The labs are not put in any particular order, right? I don't know why they order them the way they do, but they're definitely not ordered in any organ system or any what seems like a meaningful way. So for us, we actually just redo them all. We put them all in different sections. So this is the osteoporosis lab work.
So you guys know I'm always looking for unique supplement combinations. And I was pretty excited when I saw this one from 4Well called Advanced Formula Saw Palmetto for Men. Now, the company 4Well has only a couple of products, and they only put out unique formulations like this one, which has DHEA, saw palmetto, and ashwagandha. Now, you've heard me talk a lot about DHEA before. So DHEA is great because it's an androgen. It's good for your brain, for your bones, testosterone balance, body composition, muscle mass, etc. But especially at doses like this at 50 milligrams, we see androgenic side effects in some of our patients, and that includes me as well. So there would be like acne and hair loss, etc. So that's why they combine it with saw palmetto. Saw palmetto is a 5-alpha reductase inhibitor. Actually works the same way as some of the drugs that are used for hair loss. It blocks the conversion of testosterone to dihydrotestosterone, which could be a major contributor in many cases. So I've actually started taking this product, and guess what? No androgenic side effects. Now, the third ingredient, ashwagandha, is a really popular adaptogen. It's in a lot of products because it can help balance cortisol. It helps with hormone balance, testosterone balance. It's really popular with men in libido support products, etc. So ashwagandha is never a bad thing to add in. It probably adds just a little element of calming to the whole thing. So if you've tried DHA in the past without success, I would consider trying this combo out. And if you click on the link or use the code Dr. Doug, the number 4Well, Dr. Doug 4Well, you'll get 10% off.
So these are the things that we think are particularly important for osteoporosis. And you'll see some of these labs pop up in different sections or multiple sections. All right. So in no particular order, because I think the most important ones are on the bottom, but I'll just go from top to bottom. The first one is serum vitamin A or retinol. Now, this is kind of an unusual one. You don't see this in a lot of labs. We started drawing this lab because we were finding that a lot of people, when on a bone health journey, were taking a whole lot of vitamin D. They were told to. And if you drive vitamin D up, there is this theory that you'll see vitamin A come down. Could be for a couple of different reasons, competition in the gut, you can't carry them, it's something happening inside the body, whatever. We don't really know why. But we did actually see that in some patients, not consistently, but we still want to make sure that you have adequate vitamin A. And here's why. Vitamin A, retinol, the active form of vitamin A, is required for vitamin D to do what it's supposed to do in the cell. So you could take a whole bunch of vitamin D, but if you don't have vitamin A, the vitamin D actually can't work in the cell. That calcitriol, that active vitamin D, can't work in the cell. So that's why we look for serum vitamin A. And we have our reference range, our optimal range here of 40 to 70. And that's just a little bit higher than the reference range would be because the population is generally deficient. Phosphorus, I'm not going to talk a lot about phosphorus. This is sort of part of looking for secondary causes of osteoporosis, so not an exciting one. Parathyroid hormone, PTH. So this is something that really should be measured. For some reason in this patient, it wasn't measured. So I'm sure we actually had this patient retest here. But parathyroid hormone is looking for potentially a secondary cause of osteoporosis. If you have high levels of parathyroid hormone, it could be for a few different reasons, vitamin D deficiency, some other things. But the concern is, do you have a parathyroid tumor? Parathyroid tumor will cause bone loss, and there's nothing you can do about it until you get that tumor removed. So it's a really good one to check. It's not always easy to identify a tumor, so we keep checking this. We make sure that the trend isn't going up. Next one on the list is vitamin D. It's 25-hydroxy vitamin D. So vitamin D metabolism is a little bit complex. So you take cholecalciferol, and it gets converted into 25-hydroxy vitamin D in blood. Cholecalciferol is the quote-unquote D3 that we take in supplement form, most of us. It's in most products, and it's not actually D3 either, but still, this is the nomenclature. So you can measure 25-hydroxy, and this is the normal 25-hydroxy vitamin D that doctors are measuring when they talk about vitamin D. Our reference range for vitamin D is only 30 to 50. And the LabCorp reference range is 30 to 100. You hear people talk about, higher is better, 80, 100, 150, whatever. The problem is, like I said with vitamin A earlier, if you go too high, there are consequences. So super physiologic doses are not necessarily better. In fact, there was a study I did a video on a few months ago that showed that for the higher the vitamin D dose that people took, the more likely they were to see fractures. So it was not an intervention study, but it was an observational study that showed this association. So kind of interesting that goes along with this idea that more is not necessarily better when it comes to vitamin D. Now, the next one on this list is calcitriol. So calcitriol is active vitamin D. It's 1,25-dihydroxy vitamin D. And this one we started measuring because we were looking at this kind of interesting thing happening with vitamin A and vitamin D. So basically, we just want this one to be higher than the 25-hydroxy D. There's some ratios that people talk about. I've not seen this consistently to be helpful, and we're actually going to take this one out. I do like seeing it, but it's expensive, and so we're going to probably take this one out of our panel now that we've kind of done the test on that. Serum ionized calcium. This is important to remember. This is different than just serum calcium alone, different reference range. But overall, unless, again, you have a secondary cause of osteoporosis, and this is either high or low, which is potentially dangerous, or you're looking for a drug impact, like taking pulsed parathyroid hormone and Forteo, then this isn't going to be that productive because generally calcium is very tightly regulated. Serum calcium is actually not going to go up or down much, even if you are rapidly losing bone or growing bone, because, again, calcium is very tightly regulated in the bloodstream. And then the most important two, I think, in this section are CTX and P1NP. So CTX is the bone breakdown marker. I talk about this all the time. This is your osteoclast breaking down bone and the byproducts of that ending up in the blood, CTX. So CTX, if you look at the reference range as it comes from LabCorp, is 34 to over 1,000. I think an optimal range for especially women who are on HRT and men who have optimized hormones should be around 250 to 450, depending on how quickly you're building bone. And the ratio, I think, is relevant here, and I'll talk about that in a second. The next marker down here is P1NP, propeptide type 1 procollagen. So P1NP is the building marker. So we want the building marker to be going up, ideally. But depending on what's happening with your CTX, they generally don't go in opposite directions. They go in the same direction, and that's why we want to look at the ratio. Reference range, again, pretty wide, right? 10 to almost 100 is the reference range. We want it to be a little bit higher. 10 is very low. So we say 40 to 100, but ultimately we want the ratio. We got to look at this ratio. So we do P1NP over CTX as a ratio, and then the ratio we have to adjust for units. So P1NP, keep the units. CTX, change the units to the units of P1NP. That just means moving the decimal point over 3 places. So for example, in this one, it would be 35.7 over 0.115. That's the P1NP over the CTX adjusted for units. And when you do that, you get 310, which is actually really good. And then this patient in particular, her previous P1NP over CTX was 211, which was actually also not bad, but it got better. Generally, right now, we're saying over 150 is good. Higher seems to be better. And we're seeing this work out clinically as well, quicker improvement in imaging, et cetera. So I'm happy with these improvements. Now, you could argue if you look at these, you could say, gosh, her CTX went down, which is good, although it's pretty darn low. And then her P1 and P went down too. So you could get really uptight about the fact that her P1 and P went down, but her CTX went down more. That's why the ratio got better. And that's why we need to actually calculate ratios. The last one in the bone health section is IGF-1. IGF-1 stands for insulin-like growth factor 1. And this is what I consider more of like the anabolic catabolic switch. So IGF-1, when it's high, you are in an anabolic state. Your body's building, you're growing muscle, you're growing bone. When it's low, you're in a catabolic state. You're breaking down. So for people that are on, let's say, GLP-1s, somebody's on Mounjaro, they're trying to lose weight, they're calorie restricted, their IGF-1 is going to be very low. It's like low double digits. So then the opposite is true as well. So if you're eating 4,000 calories a day and you're getting great sleep and you're working out, you can see IGF-1 go up substantially, 200, 300, 400, right? It can go up pretty high. And so this is a nice tool to then use to understand what's happening. Now, this patient's IGF-1 at 86 is actually pretty low. So I would love to see this go up so that we can be confident that she's actually building some muscle, building some bone. Okay, so this is a patient who is she's starting on hormone therapy. She's definitely not optimized yet. I'm just running through what these mean. So she has natural testosterone of total of 30 and a free of 1.5. That's okay. It's pretty good. It's not somebody that I would replace, but you want to make sure you're getting total and free testosterone. Now, this is a postmenopausal woman whose estradiol was unmeasurable and now has an estradiol level of 23.3 picogram per ml. Probably not optimized yet. We got to look at the other numbers, but definitely more than she had, right? And this is probably what led to the improvement in the biggest thing that led to the improvement in her bone turnover ratio. Progesterone is now measurable at 1.6, which is okay. Sometimes we see this higher. It's a little hard to catch in blood the next day anyway, but the fact that we can measure it means that we're at least headed in the right direction. DHEA at 200, she's on DHEA. She has to be. She went from 100 to 200. So this is what we're doing for androgens for her. And then looking at FSH and LH. Now, LH isn't telling me actually a lot here. They just come together. FSH, I want to see come down. It was over 200, essentially unmeasurably high. That's really high. And now it's down to 159. I would love to see it get down under 100, under 50, and eventually under 30. We'll do this slowly over time. As her estradiol rises, we'll keep increasing the dose, monitoring symptoms, et cetera. But that's how we're looking at this. And then when we look at her lipid panel, these are not specifically related to bone health, but we always want to do this bone health journey through the lens of healthspan, right? So if I'm making your bones better, but I'm putting you at high risk of heart attack, then clearly this is probably not a good thing. So we look at total cholesterol. Not a big fan of looking at total cholesterol as much of an indicator of anything. We need to really break it down. LDL cholesterol is a biomarker that does have some risk associated with it, but I'm not a big fan of saying, LDL bad cholesterol, HDL good cholesterol. It's not that simple, but her lipids are actually headed in the right direction. And this is actually starting a diet that has more protein, more red meat. So a little counterintuitive for a lot of people, but there's some work to do here. I want to know more about her cardiovascular risk. Is this something we should be more aggressive about? The answer is maybe. Her HDL looks pretty good, around 70. Her apolipoprotein B, this is a biomarker looking at LDL particles, so the number of the particles. It's a better biomarker than LDL cholesterol by itself. And it went 141 to 116 for her. So headed in the right direction, right? So the things that we're doing are working well for her. Again, the question is, are we being aggressive enough? And so this is where we work with her. If she has a cardiologist or a primary care doctor, we're generally not managing this on our own. Triglycerides look great at under 100. Oxidized LDL. This is a great biomarker looking at the oxidized particles. And when your oxidized LDL is high, this is a sign that there's a lot of oxidative stress, or you have too many particles, or both. But hers is going down. So this is great. This is a good risk factor to look at, in my opinion. OxLDL, ApoB, these are the bigger risk factors I look at over LDL cholesterol by itself. LP little a, or lipoprotein little a. We measure this only one time. We don't repeat it. We're basically just asking the question, do you have it or do you not? This is a genetic risk factor. LPPLA2 is an interesting biomarker looking at the byproduct of plaque formation. When it's really high, it's helpful. When it's really low, it's helpful. When it's kind of in the middle, it doesn't really tell me much. But I like this as an additional biomarker for cardiovascular health. Fibrinogen is essentially like the stickiness of the blood. Again, helpful if it's high because it shows that somebody is at increased risk of stroke or blood clot, and there's something we can do about that even from a supplement perspective. Homocysteine, this is a great biomarker looking at methylation. It's potentially a secondary biomarker of inflammation. Means that you're not utilizing your B vitamins or you don't have adequate B vitamins. Something in the cycle of methylation is off. So this is a great one because homocysteine is associated with cardiovascular disease when elevated, cardiovascular disease, dementia, and osteoporosis, the top 3 killers. So this is a really nice biomarker to get. Serum B12, serum folate, we get these. What we find, though, is that if you're on B12 and folate, even if you skip them the day of the labs, they're going to be unmeasurably high. It just means that you're taking your you're taking your supplements. So again, this is helpful from a diagnostic perspective. Once you're on treatment, not particularly helpful. CRP, especially high sensitive CRP, great look at inflammation. Hers is nice and low. So this is helpful from a cardiovascular and bone health perspective and dementia prevention. Red blood cell magnesium is a better way to test magnesium than is serum magnesium. So if you're looking at magnesium in the body, it's got to be RBC Mag. Thyroid panel has to include all these things: TSH, free T4, free T3, thyroid globulin antibody, and TPO, which is thyroid peroxidase antibody, and reverse T3. So we get all of these because we need a total look at what's happening at the thyroid, not just looking at TSH. So when we look at hers, we see her TSH looks good between 1 and 2. Her free T3 looks great between 3 and 4. She does not have any antibodies, and her reverse T3 is low. This is a really nice looking thyroid on paper. Of course, we would also want to ask about symptoms, but looks really good on paper. Stress and sleep area, we just have DHEA and cortisol. It's great to talk about cortisol. It's kind of hard to capture in blood, just like any hormone. So good to measure when it's high, like hers is. We have a conversation around stress, but we don't know if it was just high because she was getting stabbed at the phlebotomist, or is it high chronically? There's some other tests you can do for that from a functional perspective. DHEA we've already talked about. Glucose and metabolic function are very important to test no matter what you're looking for. We got to make sure that metabolic health is in check. Her fasting glucose is under 100. Fasting insulin is low. A1C is 5.5. I would guess with those other numbers, this is artificially elevated. Triglycerides under 100. She's probably relatively carb restricted, I would guess, based off of those numbers, which could make for an elevated A1C. Kidney lab work, I'm not going to belabor. We just got to make sure that it's working well, looking specifically creatinine, GFR, making sure everything else kind of checks out here. Other things in here that we want to look at: albumin for somebody who is really low in protein. That takes a really significant deficiency to have low albumin, but that's real. Uric acid you want to look at from a carbohydrate consumption perspective. When someone's triglycerides are high, metabolically unwell, uric acid will start to rise. That's something to consider. Looking at the liver, AST, ALT. These are the 2 most important things that I'm looking at in here. Taking a look at everything else and making sure it checks out. Remember, when you see alkaline phosphatase on this CMP, this complete metabolic panel, this is not bone-specific alk phos. So don't read too much into this if it's high or low. Alk phos comes from several different areas in your body, including your liver, including your muscle. So it doesn't just come from bone. This is not bone-specific alk phos. You always want to look at hemoglobin and hematocrit, making sure that we don't have either too high or too low of hemoglobin in the blood. This is a marker either of anemia or potentially of iron overload, or you are overproducing red blood cells as a result of being on testosterone therapy, especially for men on injection. This is something to watch out for. And then iron studies. This is really challenging to interpret, and they fluctuate quite a bit. But what we're looking for here between serum iron, TIBC, ferritin, is we're looking for somebody who is either iron overloaded or iron deficient anemic. Those are the kind of the areas we're trying to get into there. I'm always looking at MCV. This is mean corpuscular volume. I'm always looking at MCV just to make sure we're not B12 deficient, because if you're B12 deficient, you could have a high MCV, and that would be up over 100 here. Red blood cell zinc, similar to red blood cell mag. Serum copper and ceruloplasmin are our copper measures. Again, these are kind of looking, this is part of the iron picture. So we're looking to see how much serum copper they have, and then do they have adequate ceruloplasmin, which is a protein, copper made protein that helps to carry around iron. And that is it. That's our lab panel as it stands right now. We change it, about every couple of months. So this will probably change in a few months. It'll probably change as we get into the LifeMD platform. We're always looking for what is the best lab that doesn't overload, that provides some kind of valuable insight into what we should do from a programming perspective. So I hope you found that helpful. And I want to remind you, if you're on a bone health journey and you haven't come to our masterclass yet, please consider coming to our masterclass. It's where I go over the top 5 mistakes that we see people make. And we can talk about things like biomarkers as well. We talk a little bit about labs, but we also answer questions for about 25 minutes. So if you think that would be valuable, please check out the link in the description below. It's totally free. We do this about every other week. Some months we even do it every week because we have such a high demand for it. And if you haven't done it yet, I would strongly encourage you to do it. So that's it for this video. I hope you found that helpful. And if you're having a hard time getting labs, remember that we can help people do this in the United States through our community, the OsteoCollective. There are more and more companies doing direct-to-consumer labs, but finding this kind of panel would be very difficult and potentially also very expensive. So if you need help with that, you can check us out at OsteoCollective.com. And in the end, remember that life is about acquiring memories and aging with strength and grace. I'll see you in the next video.